Once again, welcome to our monthly seminar on religion, spirituality, and health. I am thrilled today to introduce Joe Currier. Joe Currier is really a brilliant young academician who is professor of psychology at the University of South Alabama and clinical supervisor at the Veterans Recovery Resources. He's a clinical psychologist by training. His research focuses on moral injury and applied psychology of religion and spirituality. By the way, he recently published a book on moral injury, and we reviewed it in Crossroads. But if you just, Google search on Amazon on his name and moral injury clinical applications, you'll be able to pick it up. It's a great book. So he has also published 120 peer-reviewed articles in support of these lines of research, moral injury, and integration of psychology, religion, spirituality into psychology. And he has been funded by the John Templeton Foundation, the Robert Wood Johnson Foundation, and by SAMHSA. He is principal investigator of the Spiritual and Religious Competencies Project, John Templeton Foundation funded grant aimed at catalyzing systematic and cultural changes in mental health fields to train clinicians to attend to people's faith or spirituality. He served as director of clinical training for clinical and counseling psychology doctorate program at USA from 2015 to 2020, and as a Robert Wood Johnson fellow, clinical research fellow from 2018 to 2021. So he is going to talk to us about spiritual and religious competencies for mental health care, moving from research to routine practice. So we're thrilled to have you here, Joe. Go ahead and take it away. You can share your screen.
All right. Thank you so much for that introduction, and thanks for this opportunity to be together today. There was a comment in the chat, Harold, about turning on the captions.
Okay.
That is not that exceeds my capability on Zoom at the present time. I don't know, as the host, if you know how to do that. Or if someone could just advise me about how to do it, I'd be glad to turn on the captions.
Yeah, anybody give us some advice here? Verbally, unmute yourself and guide us through this.
Okay, says the captions need to be included in your Zoom settings account. So that would have probably had to happen before the meeting started.
I see. Zoom settings.
That's correct. If whoever's the host has Zoom account that includes captions, that would be great.
Okay. I don't know how to do it, but if there's some easy way to do it based on these various things at the bottom of the screen, I'm willing to do it. But if I have to do it beforehand, we're beyond that. But let's just see here, view options.
Harold, that's correct. It's something that people set up ahead of time. I can talk to you about it later. Thanks.
Okay, that sounds good. Maybe send me an email. That would be great. Okay, Joe, take it away.
All right, sounds great. Here's the title, from today's talk. And usually when I'm, speaking about spiritual religious competencies, I'm speaking to groups who kind of may be more novice, or they may be more skeptical, about the intersection between, religion, spirituality, and mental health. But I realized, this morning, that in many ways, I may be going to be teaching to the teachers or preaching to the preachers, to use a religious metaphor. So there's no content in today's talk that is likely going to be, super novel kind of, or innovative, today. That what I'm going to be talking about, would be, sort of, an emerging, set of competencies, to ensure that every practicing mental health professional, whether they're a psychologist like myself, psychiatrist, counselor, marriage and family therapist, social worker, chaplain, psychiatric nurse practitioner, I mean, the list can go on and on and on, right? That we want to, ensure that all mental health clinicians, practicing in our country, just have basic awareness, knowledge, and skills to attend to religious, spiritual aspects of clients' lives, right? So in many ways, this talk, is really designed for the colleague in the office next to you, who may not be necessarily doing a lot of work with respect to the intersection between religion and mental health, right? That if you're like me, you likely have, a number of colleagues, who may really respect you. You might have a good friendship with them, but when push comes to shove, they're probably, a little bit leery, or maybe even kind of ignorant, about, the importance of religion and spirituality as core areas of diversity and functioning in many people's lives, right? So as Harold highlighted, I'm the principal investigator, for a John Templeton Foundation grant, called the Spiritual and Religious Competencies Project. And the purpose of this overall project is, to try to promote kind of systemic cultural changes within mental health professions, to ensure that, graduate and postgraduate training programs, are not excluding religion and spirituality, from their diversity training or from, their other kind of aspects of clinical training, right? So, for those of you kind of who know history, in this area, that there was a major initiative, around the turn of the millennium, that was led by Christina Pachalski, David Larson. I think, Harold, you probably had a role to play in this project, ensuring that medical schools and psychiatry residency programs were universally providing training, in religion and spirituality. Well, it's about a quarter century later, and we're trying to bring other mental health fields kind of up to speed. So this slide kind of highlights the overall problem that we're trying to address kind of in our project, right? So there's many reasons why kind of professions are not necessarily training students in religion and spirituality. I think one of the major reasons, is that most kind of professions have not clearly articulated kind of a set of aspirational guidelines or kind of basic areas of competence that, we would universally hope clinicians would aspire to or attain, over the course of their careers, right? So, if you think about that, that the training director, if you're affiliated with, an academic institution, you have a training, program, thinking about the training director, if the program is not necessarily addressing, religion and spirituality at all, the first question that training director is going to want to know is like, all right, well, what's the bare minimum that we have to do, to ensure that all of our students or our trainees are just getting just a basic foundation of awareness, knowledge, and skills, right? Where, they can address religion and spirituality just as they need to be able to address other core areas of diversity or psychological functioning, right? So this is the problem that we're trying to address in our project. And I think one of the ways that we're trying to address it is by, attempting to identify a core set of competencies. So to this point in time, outside of, psychiatry, kind of other medical professions, within kind of major mental health care professions in our country, counseling is the only one right now, that has articulated a set of competencies or guidelines. So in order to close the gap within psychology, Division 36, which is the Society for the Psychology of Religion and Spirituality, Division 36 of APA, which is American Psychological Association, this would be the other APA, in our country, commissioned a task force to develop kind of a set of professional practice guidelines, for psychology. So this task force is led by Cassie Viatin at UC San Diego, and Carrie O'Grady, at BYU. There are about 25 of us, who are serving on the task force. And we've gone through a multi-year process of meeting and dialoguing and writing and giving feedback on one another's kind of written work, to try to drill down to kind of a core set of professional practice guidelines that we hope that every psychologist would aspire to, in their work, whether they're providing psychotherapy, assessment, teaching, research, consultation, right? All the different things that psychologists do. We want to, identify a set of, guidelines, to inform their work, right? So what you see here on this slide, would be, at right now, kind of the final set of guidelines, that we've landed on, for psychology. And what I did here was I substituted the word psychologist, to clinician, to try to make these more applicable, right? But it's important to highlight that these guidelines were developed specifically for psychology in mind, but they may have relevance, for other mental health care professions as well. Okay, so what I'd like to do today is kind of, somewhat methodically, just kind of go through each of these guidelines, right? So again, I know that I'm talking to experts, this morning, that we're in the middle of Hanukkah, we're a few days from Christmas, it's cold outside, it's rainy. Anybody who's coming out to hear this talk probably already has basic competence in religion and spirituality, right? So there's nothing here that you're going to be like, oh my goodness, I don't know if I'm competent. I don't know if I have a good, you probably do have a great foundation just by the fact that you had the motivation to be here today. But I think what is novel, is, beginning to set some targets, that could move, all of the research that people like Harold and many of you have done, to really, kind of make a case, for the cultural and clinical relevance of religion and spirituality within mental health care practice, right? Well, but if we're really going to close that gap from research to practice, the primary pathway, is going to be training. Right. So these could be possible targets of training, to kind of consider. So it's helpful to, to define what we mean by guidelines or competencies, what we don't mean. Right. So when we talk about, spiritual religious competencies, we're not necessarily trying to elevate religion and spirituality as more important than other core areas of diversity, right? So we're not trying to make a case, that training programs need to de-emphasize, addressing structural racism or addressing other issues of race or transgender or gender identity, or the list goes on and on and on and on and on around all of the intersectional realities, that human beings experience and live out, right? But we are assuming that religion and spirituality are equally important, right? So, most definitions of personal or cultural diversity, whether it's, American Psychological Association or American Psychiatric Association or other kind of professional organizations, accrediting bodies, they'll give a long list of terms, right? It's sort of the list of the sources of identity or diversity, right? And we are at a point now where all healthcare professions universally list, at least religion, in their definition of cultural and personal diversity. And this is huge. This is a major breakthrough, and it's occurred largely because of the work of people like Harold, and I imagine others here today. But when push comes to shove, practically, we know that most training programs, they don't address religion and spirituality. That in many ways, like religion and spirituality are sort of like the redheaded step cousins of diversity, right? That they get mentioned, but they don't get, any time or effort behind them, in training programs, right? So we're not saying that they're more important than other sources of diversity, but we are saying they are equally important, and they need to be addressed with the same care and specificity as other areas. We're not necessarily, attempting to propose like a new area of specialization or advanced practice, right? That what we're assuming is that, religion and spirituality, is universally important, right? And that it's not only important, when you're working with religious clients, right? So if I imagine that many of you, you may not necessarily identify as religious. You probably spend much of your time working with people that may, identify as secular or atheist or agnostic, right? And all of these different, designations that we have. What we're assuming is that this is like knowing how to work with people who are not necessarily religious is equally as important as having the awareness, knowledge, and skills to work with people who are religious, right? So this is not, a special population, that you're preparing to work with. Like this is universally important, right? We're also not assuming that psychologists, psychiatrists, counselors, social workers, other mental health care professions, that you need to go on and do another degree in religious studies or theology, right? That these competencies are based on what we know from psychological health-related research, that we're drawing on our own evidence base for, these competencies or these guidelines. Right. So like my first, graduate degree, I did a master's degree in an integrative program. I got great clinical training. I wouldn't have changed any of my decisions. But when I look back on my training in that program, I did learn a lot about, kind of like integration of psychology and theology at a really, kind of conceptual level. I had some classes, in Old Testament and New Testament, right? But I was never taught skills about how you actually address religious and spiritual aspects of people's lives in the room with the patient or the client in front of you, right? So that's really what we're trying to, to address, with these competency areas. So the first, competency area, for, clinicians, would be, kind of having, the ability, to understand, that spirituality and religion, are interrelated, but distinct areas of, cultural identity and diversity, that are very, very important, for psychological health and well-being, right? So, I imagine most of you, that there are, virtually hundreds of definitions of religion and spirituality. I think, Harold, you've done, really, really important work, along these lines as well, particularly not kind of confounding the two and getting into circular, sorts of definitions and arguments, So on the slide here, these are just two examples, of definitions that are out there, in the literature for religion and spirituality. And I'm not going to talk too much about them, but, we need to understand what religion is and what spirituality is, and how they may intersect, kind of clinically and culturally, within the patients that we serve. So this table here, this comes from one of the publications from the Consortium for Psychosocial Stress, Spirituality and Health, at kind of Harvard School of Public Health. And if you're familiar with what, the consortium's doing, is that, they've been able to, to embed or to insert, some really great kind of multi-dimensional kind of assessments of different aspects of spiritual religious backgrounds, within kind of a number of, very rigorous kind of longitudinal cohort-based studies, that do a really great job of sampling kind of ethnic and racial minority groups, in our country. So these numbers here on the slide kind of highlight, the percentages, of respondents who have participated in these studies, who endorsed kind of these different kind of aspects of religiousness, or spirituality. So as you look here at the slide, I mean, you can see, that there is some variability from one religious cultural group, to the next. I should say one ethnic racial group to the next. But you can see that religiousness, spirituality, is highly prevalent, right? So what this means is, as clinicians, we need to assume, that, whether we're working, with white or African American, South Asian, American Indian, Hispanic, Latino populations, that not everybody, but many of them, are going to, have, religious, spiritual beliefs, relationships, communities that are going to be highly relevant, for our practice. I think it's also, as we're defining, kind of conceptualizing, the best ways to understand, spirituality and religion. I think it's important to highlight, that we want to, understand the substantive elements, of our patients, religiousness or spirituality, but we also want to understand the functionality of, spirituality or religion in our patients' lives. Right. And that by nature, both religion and spirituality are multifaceted, multidimensional, constructs. So this quote, comes from kind of a review article that Ken Pargament, and some colleagues published, a number of years ago, on religious coping. And, at one point in the article, in kind of bringing things to a close, Pargament et al., shared that it is important to consider not only how much, religion is involved in coping, but also how religion is involved in coping. Specifically the who, the what, the when, and the where. Now, I imagine that this note, that many of you have probably already seen this quote, and that most of you, this is not new information, right? But as we think about that colleague in the office next to you that might be a bit skeptical, maybe even a bit oppositional to the notion that there's a really crucial intersection between religion, spirituality, and mental health, right? Like, being able to, to speak, about, religion and spirituality within functional terms and multidimensional terms, I think is really, really important. All right, the second kind of competency area, is that all clinicians will have self-awareness about their own, spiritual or religious beliefs and backgrounds, and how kind of their own beliefs and backgrounds may affect, their internal reactions to working with religiously and spiritually diverse patients, right? So, there's been kind of increasing, research, on the importance of implicit bias within healthcare practice, right? And it's really important to highlight, that just as we can, have, implicit bias, against, working with patients from, different racial groups, or gender identity groups. Well, we can have implicit bias for religion and spirituality as well, right? So if you think about, the different types of dyads, that may emerge, between, clinicians and the patients that they're serving, the graphic here kind of highlights kind of like these four quadrants or these four types of dyads that may emerge, right? So there are many clinicians, for whom, religion or spirituality might be really personally important, in their lives. It might be a core source of meaning, belonging, significance in life, right? Whether, dating back to, to childhood, or maybe this is, something that emerged kind of as an adult, right? And then, we also can work with, patients, for whom, religion and spirituality is very, very important or operative in their lives, and then we can work with patients, who identify as more secular, or who may, identify as atheist or agnostic. And that in many of these cases, the sense of identity, may be, highly motivated by pushing against, conventional or organized, kind of forms of religion. So the most common dynamic, that within mental health care practice is when we have secular clinicians kind of working with religious patients, right? That we know, at least in the field of psychology, that there's a religiousness gap, between, psychologists, and the patients that we serve. So the findings are getting a little bit old, but there's, some information out there that, that maybe 1 out of 5 psychologists, will kind of view themselves as religious, and be engaging consistently in religious practices or behaviors over the course of their week, right? But that we also know from, nationally representative surveys that are done, by Gallup and Pew and other organizations every year, that, more like 3 out of 4 of our clients, might consider themselves highly religious and might be engaging in these, religious practices and behaviors week after week, right? So there's going to be a mismatch here. There can also, be cases where, there's a religious clinician kind of working, with a secular patient, right? And in these cases, there might be, a concern that, like, I don't want to impose my bias, on this patient, or this person, checked the none box on the intake questionnaire, so I'm not going to follow up and ask about religion or spirituality at all. And that can also kind of introduce kind of issues, within, the treatment possibly, so I can, share a story of, a veteran, that I assessed, several months ago, in our Veterans Recovery Resources Clinic, so he was coming in, for issues related to depression, and alcohol abuse, checked the none box, on the intake, and then I went through my, my initial clinical interview. I got to the end of the interview, and I was, feeling, really honored, to be working with him, that he had been through, just tremendous adversity, and yes, he did meet criteria for major depressive disorder and an alcohol use disorder, but he was also showing, a lot of resilience just by the fact that he was there and that he was continuing to put one foot in front of the other. And I asked him, I said, I'm just, feeling, honored to be here with you in this moment. And I'm also just amazed that you keep on going. Can you please help me understand where you draw strength from in your life? Right. And even though I wasn't planning on asking about religion or spirituality at all, and I hadn't at all, because I didn't think it was going to be important. Right. Well, guess what he ended up talking about in that moment? He didn't use the term religious or spiritual, but he ended up, speaking, about a connection with God, and the fact that he did have this kind of this active kind of conversation or prayer life going that really seemed to be a source of strength for him. There can also, be cases, when we have, religious, clinicians kind of working with religious patients, right? Where there's synchron or secular clinicians working with secular, patients. So in many ways, like these are the cases that, can be the most dangerous for having kind of bias, or even, potential kind of microaggressions kind of emerge within the treatment, right? So if you identify, with a particular religious tradition and you're working with a patient from that same religious tradition, these are going to be the times when, as clinicians, we're the most in danger of being complacent or not being disciplined, to really do our work and to avoid making assumptions, right? So there's going to be this tendency, to assume that I understand what faith or spirituality means to this patient and how it might operate in their lives, right? There also can be, an overenthusiasm if it's a religious clinician working with a religious patient, and assume that, that because, we're of the same tradition, this means that the patient must want to incorporate their faith or spirituality within the treatment, right? And, there's a lot of folks who don't necessarily want to include it, in really clear or salient ways. Right. There can also be situations where you have a secular clinician working with a secular patient, and there might be a minimization, or a potential kind of oversight of religion and spirituality. So I can share another example, of this type of a dyad. So I just, I supervised one of our clinical practicum groups, in our PhD program, and most of this, I think, pretty much all the students in the group would identify as secular. And within the first or second week, I was, just getting to know, these students. We were watching tapes, of their session, of one of the student sessions from the prior week. And, she was working with, a 20 or something year old lesbian woman, who, was being treated for depression. In the prior weeks, so she hadn't seen this person for about a month, because over the course of that month, the patient had decided, to do a European, vacation. It was, she wanted to do, a bit of a kind of an eat, pray, love type trip, where she, traveled to Europe. She's at a bit of a crossroads in her life, trying to figure out, some career choices and, trying to kind of find herself. So, she, traveled around Europe, and, at some point during her trip, she decided to wander into, one of the old, kind of beautiful kind of churches, and, so she showed up there for the tour. And, at some point there was an opportunity to kind of sit within, the sanctuary of this historic church, and she was all by herself. And then during, that moment, she had this experience that she could not explain, so this patient, she grew up Catholic, and then, largely, because of kind of dealing with her own sexual orientation, having some very painful experiences, within her church community, she ended up kind of exiting, from faith, as a teenager, and never really looked back. But here she is, she's sitting in this church, and it's a beautiful sunny day, and in the stained glass windows, the light is coming in from the windows, and she has this experience of warmth, or this experience of being connected to something that's larger than herself. And it was just a profound experience for her. It was very, very surprising. Well, she comes to therapy to see my supervisee the very next week, and she starts the session by saying, "Hey, I had this experience that I want to talk about." in my session because I just don't know how to make sense of it, right? Supervisee begins, kind of exploring it a little bit more, and then she ends up becoming very, very emotional. And she's, crying, and it's not like tears of distress. It's sort of kind of these tears of joy and gratitude. And but I proceeded to watch my supervisee change the subject, right? Even though we train our students, you follow the affect, follow the affect, follow the affect, right? She did not follow the affect. She decided to take another road altogether, right? So we finished watching the tape, and then I explored with her, like, help me understand what's going on here. It really seemed like this was important for your client to talk about. She asked you to talk about it. She begins displaying signs of affect, and you change the subject. You go another different direction. Well, my secular trainee thought that she was doing the right thing not to talk about religion in the session, right? That somehow in our training program, she got this idea that you're not supposed to talk about it, right? It's just like, the Christmas dinner, that you don't talk about religion or politics, right? That we need to do this, carry this same approach over with our patients. So like that can be, it's just an example of how kind of matching and secularity can also introduce, some unique issues, related to bias, and that, that it was really important for this supervisee to kind of understand how her own background and her assumptions about her client's background, affected, the way that she handled that very, very important moment, or mishandled that very important moment in session with their client. All right, moving on to the third kind of competency area, is that, clinicians, have the ability, to identify strengths and resources related to religion and spirituality in their clients' lives, and, the capacity to help clients or patients access those resources for healing or recovery, right? So, obviously, Harold has done, just amazing work in this area. The Center for, Religion, Theology, and Health at Duke, has been one of the leaders, in this area. I'm really, Harold, I need to get a copy of your book, the newest edition of the Handbook of Religion and Health, but, I have had the chance to, to see some of the chapters, and that Harold, and his team, that they've highlighted, 7, causal pathways, by which, religion or spirituality kind of may, prevent, the possibility of, different mental health or other health-related conditions, emerging, or when these conditions do emerge, how, religion and spirituality kind of may promote healing or recovery, right? So, like we do know, from an amassing evidence base, that, religion and spirituality are very, very significant sources of resilience, well-being, and recovery in people's lives. So kind of the image here, on the slide is of a live oak. So I don't remember if there are any live oaks, in the Durham kind of Chapel Hill area, but we see these trees kind of, throughout the Southeast. We have a lot of these trees, here in Mobile, Alabama, where I live. And that as you look at the tree, just notice, the beauty and the complexity of the root system, right? So like, here in Mobile, we get 1 or 2 hurricanes a year, but somehow like our city is just, kind of inundated with these live oak trees that have been around for hundreds of years. So somehow they find a way to withstand storm after storm after storm, right? And how do they do that? Well, one, they have the capacity, they root very, very deeply, right? And that the roots, are just as beautiful and breathtaking, as what we see above ground. But like I've had the opportunity to watch a live oak kind of in, withstanding a hurricane. And even though they're huge and they're strong, they also have the capacity to flex with the winds, and the storms. Right. And that in many ways, like this is, how like an integrated faith or spirituality operates in people's lives. One, it helps us to root very, very deeply in our beliefs, our values, our relationships, but also gives us the capacity for flexibility, and to adapt, to the challenges of life. Right. So, there's a meta-analysis of longitudinal studies, that have been done, on the intersection between kind of different aspects of religion and spirituality, and health, and what was, somewhat rigorous and innovative about this meta-analysis is that, they were able to identify the effect sizes when they were accounting for, the prospective association between, the health-related outcome at the 2 time points, right? So, if they were, wanting to see like what's the association between religion and depression, they're able to control for the effects of depression at time 1 on time 2, and then look to see what the strength of the association was between, the aspect of religiousness or spirituality, and the health outcome. And they were able, and they showed that, yes, indeed, that engagement in public religious activities, the importance, of spirituality, religion, that these did emerge as statistically significant effects, right? And, and I know that many of you are aware of these findings, of all the different aspects of religiousness in particular. Communal forms of religiousness really seem to be, generating the strongest effects. So I think for better or worse, we are at a socio-cultural political moment where I think, there's, kind of, concern, kind of controversy, kind of over conventional, kind of organized forms of religion. But like we do know, from research, that participating, in a faith community of some sort, it really does, seem to confer resilience and capacity for recovery, for many people, and that there's been kind of an increasing number of really well-designed, kind of longitudinal cohort studies, that are, consistently documenting that, participating in religious services and kind of other aspects of community religiousness really does seem to be important. So I just have some of the studies up here, on the slide. I'm sure that, that Harold, and his team, provide, good reviews, good summaries of these studies in their newest edition. So Tyler Vanderweel from Harvard, and in a review of this work, he made the statement that it may be the confluence of the religious values and practices reinforced by social ties and norms that give religious communities their powerful effects on so many aspects of human flourishing. So that quote really sums up, what we know, from research. Notwithstanding the strengths and resources that religion and spirituality can provide, that religion and spirituality can also be a source of pain and struggle, in people's lives. So for those of you, who work with severely mentally ill, people, you'll know that, there's often, a confounding, of, religious beliefs, and expression of, kind of different with yesterday, I did a consult, with a Christian woman, who lives with scrupulosity, and she's been, experiencing, a significant flare up in her OCD, over the last kind of year or two. she's that's my alarm to stop talking here pretty soon. She's been married for about a year, and I think, you know, these issues are creating a lot of distress and tension, you know, in her marriage. You know, but, you know, she, you know, essentially has, you know, about 8 to 10 vows, you know, that she has made to God. And, you know, she devotes, you know, tremendous emotional, cognitive resources, you know, to trying to fulfill these vows and live out these vows kind of day after day, right? So, you know, so there's a pastor here in town who knows that who trusts that I am, you know, spiritually competent, you know, to care for his person, you know. So, you know, I did an initial consult with her yesterday, and, you know, this would be kind of an indication, you know, at least with respect to OCD, that her OCD expressed, you know, primarily within kind of religious cognitions, beliefs, behaviors, right? And, you know, this is another example of, you know, kind of different ways that one's faith kind of may cause issues, you know, within the psychological, you know, or mental health domain. To date, probably the most research, you know, on kind of the darker side of religion and spirituality has kind of been on the topic of spiritual struggles. You know, so spiritual struggles, you know, so the concept, you know, that was originally, you know, developed by Julie Exline, you know, at Case Western University. Ken Pargament also, you know, has worked really closely with Julie, you know, over the years, you know, and this is, you know, a topic that has, you know, in many ways just sort of taken the world by storm. You know, so kind of different kind of forms of struggle. You can see here on the slide, you know, there might be tension, you know, with God or the divine, interpersonal, I mean, issues in interpersonal relationships with kind of fellow believers or religious leaders or institutions, doubting spiritual beliefs, feeling, you know, concerned about, you know, not living up to standards of moral perfection, feeling, you know, a sense of ultimate feeling a painful void of ultimate meaning, you know, in one's life, and that in all of these cases, one's faith or spirituality is aggravating or introducing distress, you know, in one's. To date, you know, there's been, you know, roughly, I would say, you know, last time I checked, there's been about 30 to 35 prospective longitudinal studies, you know, on the mental health related effects, you know, of spiritual struggles, you know, and what the research is really pointing to is that, you know, that when studies are able to track people over time, you know, so we've done several studies with military veterans, you know, in our lab, you know, we did a study with psychiatric inpatients, you know, from a big behavioral health center kind of up in Michigan, you know, several years ago. And, you know, people have studied other populations and kind of clinical groups as well. But what the research is showing, that when you're able to follow people over time, you know, where you're assessing, you know, the mental health related problem or symptoms, and, you know, the severity of spiritual struggles, you know, that, you know, spiritual struggles, you know, predict worse distress over time and lower probability of recovery, you know, over time, right? So that these, you know, being able to identify these spiritual struggles when they're present and find ways to address them in treatment, which may mean referring to a chaplain or a clergy person, you know, in one's community, you know, might be indicated, but these are highly I relevant. The research is showing. Yes, I won't talk too much about this slide, but, you know, if we had more time, you know, I outline kind of different kind of models, you know, to conceptualize the association between spiritual struggles, you know, and mental health symptoms. So I think these models and findings come from a study that we did with military veterans, you know, here on the Gulf Coast, and suicide risk. But most of the research is supporting either a primary struggle model, where the spiritual struggles seem to be driving the mental health issues, or a complex or reciprocal struggle model, where there's kind of a synergistic link between the two over time, and that one seems to be worsening the other over time. So as clinicians, we have to have the ability to identify when these spiritual struggles are going on and find a way to address them in the treatment, because they can diminish the prospect that our patient is really going to get better. Not going to talk too much about this slide. This slide comes from a study that we did, with the inpatient psychiatry program up in Michigan. We were interested to see which of the primary forms of spiritual struggles, seem to be the most predictive of issues of depression, and lower probability of recovery, when they're in the program. And long story short, we found that issues and ultimate meaning really seem to be the most clinically relevant, at least in this patient population. All right, so far I've spoken, about kind of awareness and knowledge-based competencies. Our task force very strategically decided to only focus on one skill-based competency, right? Because we're trying to set the bar low here, with these competencies. But if there's one thing that we would hope that all mental health clinicians would do, is routinely inquire about and assess for religious and spiritual aspects of clients' lives, right? And that in doing so, we really want clinicians to have cultural humility for religion and spirituality, just as they have cultural humility for other aspects of diversity or identity, right? So I just have one of the there's a lot of definitions of cultural humility out there. This definition comes from the work, of Josh Hook. At our Veterans Recovery Resource Clinic, we actually include this cultural humility assessment in our routine outcome monitoring procedures. So we really value, cultural humility, in our clinic. I won't talk, too much, about these items, but these would be a set of 4 kind of initial questions to begin, the conversation, about religion and spirituality. So I imagine that most people who are here today, that you've had really, really great training in spirituality or religion assessment, right? You probably have an approach that works for you. So Dr. Pachalski has the FICA. I know that's used a lot. It's a great approach. These are just a set of items that we're using, in our clinic that are working pretty well. So every single one of the clinicians in our clinic, have been trained, to ask these questions, right? So at the intake assessment, every single client, is asked, do you view yourself as a religious or spiritual person? Now, if someone says, no, I don't, there may not be a need to go past the first question. But if they say, yes, I am, then that might be followed with a prompt. Well, in what ways? Help me understand what being religious or spiritual means to you, right? Because one of the things that's happening, is that people are using kind of more and more sort of idiosyncratic terms and understandings, about religion and spirituality. So as clinicians, we really got to try to see things from the patient's perspective. Now, in working with veterans and trauma survivors, it's very, very common, for people to answer no to all these questions, right? But what I have found is that, the people who are often struggling the most, they've often had like really, really significant changes in their religiousness or their spirituality, right? Where they may be moved from being very highly conventionally religious, as a teenager or maybe a young adult. And then, at least for veterans, they may go to, they may enlist in the military. They fought in the Iraq and Afghanistan wars. They may have had multiple deployments, right? And then as a result of coping with those experiences, they may have had some spiritual struggles or other issues, and a way of coping, they then distance from religion and spirituality, right? But they might still be really struggling in this area. So I found that it can be also helpful that when people say no to these questions, to just consider asking them, over the course of your life, have you had any changes in your spiritual beliefs, practices, or relationships? If you would have answered these questions 15 years ago, maybe before you served in the military or before your trauma happened, would have you answered these questions differently? And as a clinician, I found that, that like this type of inquiry can provide really, really crucial information, to inform treatment. I'm not going to talk too much about kind of integrating kind of spirituality or religion, within intervention, except to say, kind of in a paper that Stephen Saunders and colleagues published, a while ago now, but it's really helpful as they introduced this continuum of spirituality integration within mental health care. And I think it's really helpful, and I won't talk too much about these categories except to say that, they sort of propose this idea that, psychologists, clinicians, we really want to be within, the middle of being spiritually conscious, spiritually integrated. There's been almost 100 controlled studies, of looking at the effects of incorporating religion and spirituality within the context of psychotherapy, and the results, are pretty encouraging. That when you compare spiritually integrated psychotherapies against psychotherapies that do not, incorporate, faith or spirituality, I think we find that, they tend to be equivalent, so they're not, making people worse. They don't appear, they tend to be equivalent for psychological outcomes, but they seem to generate better results, for spiritual outcomes. Here's the website, for our spiritual religious competencies project. I would encourage you to check out our website. It's not just going to be, a source of information, but we're hoping here in the next year or so, to begin to develop a repository of training resources. So if you're, a faculty member, if you teach, if you supervise, if you're involved with any type of training program, we're going to have, a slew of resources for you or your colleagues, to hopefully incorporate in your work. To ensure that everybody who comes out of your program or who's involved with your program, has basic awareness, knowledge, and skills, to address clients' faith or spirituality. All right, I will go ahead and stop here, and hopefully I've saved a few minutes for questions.
Thank you, Joe. Boy, what amazing work that you're doing. Truly amazing. You do such a good job of describing it as well. So we have about 5 minutes for questions. Feel free to unmute yourself and ask your question. This asking Joe questions now, if you have any issues, this would be the time to ask them right now. So go ahead and unmute yourself and share your questions with us. You don't have to raise your hand. You can just ask.
Hi, this is John Betts. I'm in Atlanta, Georgia. Nice to meet you, Joe. Thank you so much for this. One question: could you speak to some of the intersection between moral injury and spiritual struggle?
Yeah, that's actually one of my favorite things to talk about. Harold, did you plant this question? I'm just kidding. So we actually did a study on this topic that was published in a special issue of Journal of Traumatic Stress. I think it was 2019. And what we found, was, that, for people, whose kind of moral beliefs and values have been strongly shaped by religion or spirituality, right? That in these cases, there's going to be, a fairly strong likelihood that they're also going to be displaying spiritual struggles, right? But in cases when, people may be kind of more secular, maybe religion or spirituality has never been a really important part of their life, at least in really explicit ways, you're not going to be as likely to see spiritual struggles, right? So I think for me, like spirituality is not, and I should say moral injury is not an inherently religious or spiritual construct. But, just like other mental health related issues, it can be very, very, religious kind of or spiritually themed when you're working with, someone, who has, a certain type of, religious, spiritual, cultural background. So in the study that we did, we actually had a couple of big samples of community dwelling veterans, where they completed, our moral injury outcome measure and our kind of religious and spiritual struggle scale. And what we found, was that, of those folks who were reporting, kind of moral, like showing signs of being morally injured, that there was kind of one group, who really didn't report much in the way of any spiritual struggles. But then there was another group, that reported very, very high levels of, feeling angry or abandoned with God, feeling very alienated, from, religious people or institutions, leaders, kind of in other spiritual struggles. So there did seem to be like a spiritual subtype of moral injury, right? And I think Harold, you were the one who initially proposed this idea, several years ago, for the kind of spiritually integrated CPT, so I do think it can be highly relevant in moral injury, but it's not going to be relevant for every single moral injury case. I don't know if hopefully that answers your question.
That's good. Okay, who else? We've got time for about one more question. So this
I have a question.
Yeah. Okay.
I work as a spiritual care professional at the Douglas Mental Health Institute in Montreal. So I'm just wondering, you had mentioned chaplains earlier, and I was just wondering if in your research, are you looking to spiritual care professionals to help bridge the gap between the religious secular discrepancy that you described earlier?
Yeah, absolutely. So, the sixth guideline that I didn't have a chance to talk about, for mental health clinicians. So this would like exclude chaplains, but this would just be for us psychologists, psychiatrists, counselors, marriage and family therapists, social workers. I'm sure I'm missing some groups. So the sixth guideline, is that, as mental health professionals, that we practice within our scope of competency, right? So that means that we pursue formal training, education, to make sure that we have that foundation. But when we encounter cases that exceed our scope of practice, that we're willing to then partner with chaplains or clergy or other religious spiritual professionals to close the gap. Right. So thinking about the scrupulosity case that I mentioned, a moment ago, so in speaking with this woman, she needs a psychiatric referral, and she needs exposure with response prevention. Right. And that's what I can do. And I can make sure that she gets those resources. She also needs a chaplain or a theological expert who can tell her that, like these religious cognitions you're having, this isn't actually what the Bible says, or this isn't actually what, most people in our tradition believe, right? So like when someone, has to begin venturing into the realm of theology, or scriptural interpretation, right? This exceeds scope of practice. And this is where it's not the only way, but one of the ways that, having chaplains around or other spiritual professionals is really crucial, so, but again, most psychologists are not trained how to work with chaplains. Right.
That's
and
good.
Yeah.
That's good. Anybody have another question? We have truly only time for one more question, and we'll give you about 10 seconds to ask it. Camelia, go ahead.
I realize thank you so much for this presentation. It's so relevant to my practice. This is a tough question. I'm hoping for a quick answer, but just in case you have it, for people with a moral injury, for people who have been very disappointed by their church, by their religious tradition, by their priests, but they still have that longing to connect with God, and they come to clinical attention and they don't really want a chaplain in the session. I almost feel like they want something from me, some sort of validation that God loves them or God exists. Do you have a way of approaching that to make sure that they get what they need without actually going beyond what's professionally accepted?
That's an awesome question. So I think my answer would be, it would really depend. Like, so I think about being put in that situation as a clinician, and I would want to make a statement where I affirm the person's divine worth. I affirm that God loves them, but that in doing that, like, am I possibly, is that my role? I guess, right? So but one thing that I will say, so you're sort of talking about a case, where someone could be experiencing moral injury, and that maybe they can also be experiencing profound divine struggle, right? Or it could be interpersonal spiritual struggles, right? But they have these spiritual struggles that are really, really painful. Well, and then, and then as a clinician, when you try to address them, it's like you're touching on the most painful part of their life, and it hurts, right? Well, that's what we do in psychotherapy, right? Like, we're not going to necessarily collude with avoidance for other painful areas or topics. So finding a way, I mean, obviously, we need to honor our patients' choices and autonomy, but somehow finding a way to address the source of the pain, and if that's, anger or abandonment from God, finding a way, to inquire and facilitate a process where they can begin to heal that pain. And this is where, like as mental health professionals, like we have the training already to do this. We can do this with other painful areas of people's lives without necessarily knowing about the person's theology or scriptures, right? And this is where, as we do so, then, I mean, obviously the best practice would then be to try to, develop the trust where we then can get them connected with a chaplain or someone who might be able to address the theological or kind of scriptural aspects of their tradition. I don't know if that makes any sense or not.
Yes, it kind of gives us permission to go one step further if needed and help.
Exactly. Like, I think, I think so. One of the things that we're really trying to emphasize, as we try to roll out, these spiritual religious competencies, is like trying to help clinicians in some ways to expand their frame of reference, that we have all this clinical training already, expanding our clinicians' frame of reference to address spiritual religious content when it's relevant, right? So like thinking about using Socratic questioning, right? Core clinical skill that most psychologists are going to be trained in. You can do this when use your Socratic questioning, use your empathy to try to promote healing, productive, fruitful conversations about spiritual struggles.
Thank you so much.
Thank you, Joe. Terrific presentation, and thank all of you for participating in our seminar here. Have a Merry Christmas, Happy Holiday, Happy Hanukkah. Just have a great holiday season, and we'll see you next month.